Hello, everyone. Welcome to the Center for Global Development. My name is Janine Madan-Keller. I'm the Deputy Director of our Global Health Policy Program. I'm really delighted to welcome everyone here joining us in person and those tuning in virtually from around the world. Today, we're really pleased to have Seth Berkley, CEO of Gavi, the Vaccine Alliance, join us for a discussion with my colleague, Amanda Glassman. Since Gavi was founded, as many of you know, it's made a lot of remarkable progress on developing vaccines around the world, and it's being held up as one of the most cost-effective health interventions. But even before COVID hit, global immunization efforts were running into a lot of challenges. In some cases, coverage was not at global targets, and it was below levels required to achieve herd immunity. And since Gavi was founded about 25 years ago, the global health landscape, and indeed our world, has changed in so many ways. Just as one example, we're seeing a greater push to shift decision-making closer to the national and local levels. And of course, as many of you all know, the pandemic made all of these challenges even more difficult. We witnessed historic backsliding in routine immunization, saw a resurgence in vaccine-preventable diseases like polio and measles. And Gavi, much like many other global partners, was balancing an evolving role in directly responding to the pandemic, along with its core focus on delivering routine immunization. But despite many of these challenges and admittedly large gaps in equity, we also saw what my CGD colleagues have demonstrated was the fastest rollout of a new vaccine in history. The experiences, including those of initiatives like COVAX, have yielded many lessons about manufacturing, purchasing, financing, and delivering vaccines that I hope we'll hear more about today. We're also seeing a global economic slowdown. High levels of debt and rising inflation is putting pressure on countries' ability to spend on health and squeezing donor budgets. All of this is likely to have an effect on global immunization efforts. All of these themes intersect with work that we've done previously and continue to do here at CGD on issues like cost effectiveness, value for money, and equity. We'll continue to share analysis and watch many of these issues as Gavi undergoes an important leadership transition later this year when Seth steps down as CEO and as Gavi looks ahead to its next strategy and replenishment. So back to today's event. Amanda serves as the Executive Vice President and Senior Fellow at CGD, and she's going to be talking with Seth about the lessons learned from 10 plus years and looking forward to the challenges and opportunities that lie ahead for Gavi's next chapter. Dr. Seth Berkley is a medical doctor and infectious disease expert. He served as the CEO of Gavi since 2011. Previously, he founded the International AIDS Vaccine Initiative, where he served as president and CEO for 15 years. He's also held previous roles at the Rockefeller Foundation and the US CDC. He sits on several international steering committees and has held numerous academic appointments. And last year, he was elected to the US National Academy of Medicine. Welcome, Seth. We're really looking forward to hearing you share your insights with us. I'll hand it over to Amanda and Seth. Welcome, everyone.
Thanks so much, Janine. So just to say before we get started, for those of you who are online, you can submit, or even if you're listening in the audience, you can tweet at us at CGDev or hashtag CGD Talks with your questions and comments, or below our YouTube feed, or sending us an email at events@cgdev.org. So let's start. Actually, I started the Center for Global Development, you're just reminding me, at the same time that you started at Gavi. So I've really followed this organization and your leadership for about a decade. And I'm excited to be here with you to talk about how it went. And so let's start off with, just for people who might not be as familiar with Gavi, what has the Alliance become? Where was it when you started? And what have been the major achievements? Of course, you also had the episode of COVID-19. So I'm sure that was hugely consequential. So over to you for a couple of reflections to start us off.
So thanks for the nice introductions, and great to be with you, Amanda, because I've followed your work in this time as well, including the work on Gavi. So a lot of interactions there. So let me go back a little bit further. And when we look at the history, immunization in the 70s, less than 5% coverage of the simple antigens in developing countries. So there was a push to try to get vaccines out. And it went through numerous iterations. You had Jim Grant, and he declared universal childhood immunization. Then you had the Children's Vaccine Initiative, bold new idea that really failed. And Gavi was a new experiment when it started. And given that the previous episode had failed, you might think it would fail as well. And what was the premise? The premise was that vaccines are some of the most cost-effective interventions. The challenge was new and exciting vaccines were appearing. They weren't getting into developing countries either at all, or they were having a 10, 15, 20-year lag. So that was the premise to get it started. And it's been a remarkable success. Sometime this year, we don't know the official time yet, and so we don't have the data for the end of last year, but we passed the billionth unique child vaccinated by a Gavi vaccine. If you look at that accomplishment during this period, we've seen a 70% reduction in vaccine preventable deaths. We've seen a 50% reduction in under 5 child mortality, which is a contributor towards, not necessarily, the only cause of, but there's been some dramatic effects. We've launched 562 new vaccines. And this has had an enormous economic effect on countries. Now, to go on the question, in the introduction, it talked about, perhaps not meeting targets. When we started, coverage rate was around 59% for the vaccine we used to measure, which is a DPT3 vaccine. Before the pandemic started, we had about 90% of the world's population received at least one dose of a routine vaccine. Now, that last 10%, the ones we call zero dose, 2/3 of those are below the poverty line, and 50% of the child mortality is occurring in that last 10%. So that was the goal we set our eyes on to be working on in this period, to try to get as close as we could to the idea of leave no one behind and universal health coverage.
And so those are very large numbers. And then in end of 2019, early 2020, as we all know, COVID-19 hit, and there was a whole new set of challenges facing both routine immunization programs and, of course, the development and deployment of COVID-19 vaccines, and an enormous amount of uncertainty at the start of this process. So talk us through those early days and what happened with respect to Gavi's role, the creation of COVAX, and then we'll move on to sort of what lessons you would take home from that.
So if you go back to the previous pandemic of swine flu, there was a push for vaccines. Vaccines were produced. And what happened was all of the vaccines that were produced were bought up by wealthy countries, and none of them went into developing countries. So we went into this with that as being the history. And it actually started at Davos, which is, by the way, where Gavi started, not that coincidence, but it happened to be January in 2020. We didn't know if really there was person-to-person spread, although there was the suspicions of that. It had been a point outbreak, and Richard Hatchett and I sat down and said, how do we, if this is the big one, or if it's not the big one, it's the dress rehearsal for the big one, how do we get a different outcome? What do we need to do? And that's where COVAX really had its origins. A lot of work went, and you were involved with some of that on how to structure it, what to do, how to think about it. But the idea was to try to make sure that vaccines would be available for developing countries. We had one big question in that, which was, which developing countries? We traditionally we had been 73 countries. Countries had graduated as part of the Gavi model. So, should it be the Gavi 56, 57, depending on which you count in there? And the decision was made to make it AMC 92, so the 92 poorest countries, and that was linked to the World Bank list. But we also decided to include self-financing countries. And the idea there were countries that were higher income who would have problems getting access because they were small or they were under embargoes. And that, in a sense, was the most efficient way to get vaccines out. So that was was the model. And of course, we had no money, we had no vaccines, we didn't know if any of the vaccines were going to work. And we went ahead and raised capital. Donors were very generous. They allowed us to use the money from the AMC for pneumococcal, the money that was left over to jumpstart it, and then also were willing to put money on the table. And we were ultimately able to have orders for more than 4 billion doses. Now, it did not go as smoothly as we would have liked. On the good side, we had our first vaccine rolled out 39 days after the first high-income injection, which is, by far a record. Obviously, you want them the same time, but 39 days, not so much slower. And we then had a month later when there was WHO pre-qualification or emergency use authorization. We had our doses into Africa, and another 60 days after, we had doses in over 100 countries. So, in a sense, we started out on the right foot. But then we had a combination of vaccine nationalism, export bans, and at the end, it really there was a panic for doses, and the doses went to wealthy countries. Countries wanted to vaccinate their entire populations before they helped anybody else, rather than just high-risk populations. And we ended up adapting and adjusting, and eventually having asked for donations, which donors stepped up because they had bought as many as 5 vaccines per citizen, and so we had to build that facility at the same time. So lots of challenges which we adapted and adjusted to. And where are we today? We're at 53% coverage in the AMC 92 for a full course of diseases. That compares to 64% globally. Still not equity, but closer than almost anything else in terms of the equity between those populations. The things that really matter in the high-risk populations, 81% in health workers in low-income countries compared to 89% in high-income countries. And for the elderly, 68% versus around 80%. So, still not where it should be, but I think a real movement. Let me just say some of the lessons, and then we can go into some more detail. So, first of all, we really need to have contingent financing available. Had we been able to put orders in, start tech transfers immediately, it would have made a difference. The time it took for us to both put an investment case, go out, raise the money, and then actually have the money allowed countries to put order in after order, and that meant that doses weren't available. You have to be able to take risk. This is, I think, the single most important lesson. We had to convince the donors, and they went along with it, that we should be able to buy vaccines before we knew if they worked, and to go ahead and buy multiple vaccines, not knowing which would work. And that's really important. And because Gavi was able to take that risk, we were able to do this. Many other institutions couldn't take that risk and yet said they were going to do this, and they were unable to buy any doses. We also had to build in things like indemnification and liability because, those were important moving forward. But I think, the last thing I'd say on this is that for us, we always bundle delivery money with the vaccines. And we didn't do it this time, partially because the vaccine shortage was the acute thing, but also everybody else was saying they had money to spend and they were going to do this. And that ended up being a mistake because we probably should have been working on those delivery systems, because when others didn't deliver, donors came back to us and said, okay, you guys have to do this now. And we ended up scrambling a little bit behind to be able to do that.
Yeah, but let me ask you 3 follow-up questions. First, there was a lot of discussion about IP as a barrier to access. Can you reflect on that? Second, this issue of risk and uncertainty. What do you think would have happened if some of the vaccines purchased hadn't worked at all? What about the Chinese vaccines? Was there an opportunity to buy earlier? They weren't as high efficacy as some of the ones that came out of the US and the UK. On the other hand, they were available earlier. And some countries that went earlier, like Chile, they purchased that, then they shifted. But, can you reflect a little bit on that? And then third, what is the counterfactual, really? You're alluding to it with the swine flu example, right? What if we had a new outbreak or large-scale pandemic tomorrow, and there's certainly reasons to be concerned about that. What would we be doing in the vaccine space? How would it be different? Would we use the same institutional structures? Can you reflect on all of that?
Yeah, let me see if I can remember all of this. This is a test,
remind you.
memory test. So to start off on the IP, it was a challenge because here we were in the middle of this emergency, and there was a whole community that said, this is what we have to do, and focused on it and pushed on it, and it was irrelevant. And this is the tragedy. It's not that if I thought that doing a TRIPS waiver or allowing transfer of IP would have gotten us to vaccines faster, I'd be at the front of the line calling for that. The fact is that vaccines are about know-how. They're not about intellectual property. Of course, there is some intellectual property associated, but without the know-how, you cannot tech transfer and accelerate a vaccine. So the question I asked was, if you take away patents, do you increase the incentive for tech transfer or do you decrease it? And if you increase it, again, we should do it. If you decrease it, we shouldn't do it. So we ended up with a lot of people spending a lot of time fighting that battle instead of fighting the real battles that were there, including getting companies to be transparent on where these doses were going and whether, because the problem we would have is we'd have a deal with company X. Company X would have problems in production. Of course, everybody was moving maximally. There were supply issues and restrictions. And they say, we can't produce your vaccine, so you're going to delay them. The question was, are they delaying them for all their customers, at which point then it's a fair thing, or are they giving their wealthy customers vaccines and delaying them for COVAX, which is what I suspect that happens sometimes. We didn't know that. So where were the activists coming out and helping us ask those types of questions or fighting those battles or trying to stop export bans and make sure that there would be availability? So anyway, we had the experiment done. There was a TRIPS waiver, and it did nothing. And I think we need to keep that in mind going forward. Again, not to say that the patent situation is the right thing or is always having the incentives in the right place, but it wasn't the problem in this case. And it was unfortunate that so much energy was put into that. The third question, the second question was?
Oh my God, not even I remember.
She doesn't remember it.
See, that wasn't smart. Risk and uncertainty.
Yes.
What would have happened if none of the candidates had worked?
So that's a really interesting question, because on one side, everybody cheered us on, go for it, go at it, this is really important. And then, the press came out and said, oh my God, there were 10,000 doses that were thrown away somewhere. And all of a sudden that became really anxious, from our donors, from others. Now, we don't like wastage anywhere. But one of the things that, again, would be a lesson is, it is really important in a pandemic situation to make an excess of vaccines and to be in a position that if you have to, you have too many rather than too little. And so, and I actually suggested this to the G7 and G20 because when, every country, we don't know what the waste was in high-income countries because nobody was transparent about it, but it was not trivial. And the challenge in doing this is that everybody's afraid to say that because they worry about what the opposition will say. Instead, we need everybody to say that this is what we're doing and moving forward. So we certainly had that concurrence on risk, but I think it would have been a very hard conversation to say we invested all this money in this product and it went nowhere. And that's the mindset that we really have to shift because in a pandemic, you want to take multiple shots on goal. Now, we were really lucky. It turned out it's really easy to make vaccines for this pathogen, and that was the great success, 327 days for the first vaccine, that was being used outside of clinical trials. So that's great, but that may not be the case next time, and how do we get people to really, think about that? And then you asked about the counterfactual for, what would happen. And, if there was like an H5N1 outbreak or something like that could happen, would we be in a better place? Well, first of all, I think the science was the great success here. The markets, maybe not so, but at the end, more than 11 billion doses were made in 2021. That's way beyond we thought was possible. So, the pharmaceutical companies and contract manufacturers did step up. with the new technologies, I think the validated technologies may be faster, but of course we don't know whether mRNA vaccines will work for all pathogens. In fact, we have recent data. If you look at Moderna, for the first time it worked for RSV, so now it became a platform technology and not just a one-off. But they also released information on flu, and it didn't work for flu B, which I suspect they'll be able to work and change and adapt. But the point is, we don't know if that technology is going to be available. So we're in better shape with the technology. I think what's really important now is that we look at the lessons learned from the effort, because there are many people who say, oh, COVAX was a failure. I mean, we've delivered 1.9 billion doses. The coverage rate is 53% in the poorest 92 countries of the world. It's hard to call that a failure. Now, was it perfect? Were there things that really didn't work well? I mean, an example would be the humanitarian buffer. I think it was great that we put the humanitarian populations on the agenda at the beginning, because that's the right thing to do. But we had real problems because we couldn't get companies to release humanitarian organizations, CSOs, from the liability. And of course, the question is, who holds the liability if you're a population that isn't, governed by a state? And so, yes, it failed, but we know why it failed. So you don't just say, okay, it's failure, forget about it, let's start something new. Question is, what are we going to do to fix those problems? We need to go through every aspect of what happened and ask the question, what were the blockades? What could we do to make that better? And then how are we better prepared next time? And I hope that that's the way the world is going to do it, and not just, throw things away without understanding.
I mean, part of the issue is sort of who leads that process, right? Of sort of looking across these issues, looking across the different sources of financing. As you said, you were fundraising during the entire period. It's not like you had a bunch of money at the start where you could buy a diversified portfolio of vaccines. You really had to make bets in a way that was vulnerable to supply shocks like the export ban. Institutionally, what are your ideas in terms of how to proceed? And it's okay to say maybe you'll come back after you leave, Gavi. We'll have another tell-all session, so please join.
First of all, I think the smart thing is to have the people who have the expertise in the specific area to use that expertise to move things forward. So, and why do I say that? If I look at why COVAX was able to do what it did, and it was extraordinary. So we also didn't have any staff. We didn't have money. We didn't have staff. These were new companies we were working with, new countries. The reason we were able to do that is we had relationships with all of the immunization teams. We had built the cold chain systems with countries. We knew what to build onto that. We worked together with all the people in the immunization community. So there wasn't about trying to figure out which skill sets belonged where. We just called everybody together and we supported countries in moving forward. So I think what you want in the next pandemic, if it is a vaccine-related disease, to have that community, to have the alliance be at the front lines of that. Now, as I said, there are things that we learned, and there should be more money, and there should be a lot of the things we did should be evergreen so that we're ready to go and do that. But the next one might not be vaccines, although I will say that of all the public health emergencies of international concern, all of them were vaccine-related diseases except for Zika, and if we had a vaccine, it would have been. Yeah. But what you want is a network of institutions and players that can move forward and can scale up and scale down depending upon what the needs are. That should be loosely coordinated. WHO should be the coordinator of that. But I wouldn't suggest setting up a new institution or new place or taking an institution that does something else and now saying you should be in charge of this, because it will not move as quick. It will not have the ability to pivot and be resilient and adaptive, which is the critical thing to do in a pandemic.
I mean, we probably have to work in a networked way in any case. But another often heard commentary on COVAX was the sort of lack of involvement of civil society, a sense from some of the governments who were participating that they weren't necessarily getting the information they needed. I mean, the other thing I can imagine is that you're building the team as you go. It's hard, and the communications, the scale of the communications and the all the time element of it must have been extremely intense. But can you reflect a little bit on that set of issues?
So, I mean, first of all, it is correct. We did not communicate as much as we should. but there was also a problem. So the first thing we did, as soon as we had what we thought was a reasonable projection of vaccines, because remember the panic, everybody in the world was calling and wanted vaccines, we put out a forward plan for 6 months. And then the export ban hit, we had delays, and all of a sudden, even though this was an indicative forecast with every caveat in the book, you know, people published on their national newspaper front pages, we're getting this number of doses here, and all of a sudden, countries are calling up and said, well, where are the doses? You promised us this number of doses, et cetera. So there was a lot of pulling back from that. And one of the questions in that circumstance, is it better to, you know, to communicate that and then have to pull it back, or is it better to wait for more certainty? And so this was one of the reasons that we were so, you know, struggling with communications at this point. There were things we just didn't have definitive answers on. Even when we, for example, started the dose donations, countries, of course, said, I want to hold on to them as long as I can to see if my citizens need them. And oh my God, they're getting close to expiration. Here, you guys take them. And for a while then, of course, we were giving people 2 weeks notice, you know, and when you're desperate, you take it in 2 weeks notice, even if it has a short expiration point, but that's not the way we should be doing, you know, business, and we don't believe, and we didn't start with donations. So there was a real challenge in this, but there's no question we could have done better communications, and we were as inclusive as we could be, but again, the question is speed versus full inclusivity. We had civil society involved in everything we were doing. They were part of the main CCM, we called it the COVAX coordination mechanism. They were on all the subcommittees. But again, we could have done more, but it's a trading question. Same thing with developing countries whose voices were involved, and you know, on a one-on-one, but also we formed special governance groups where they would come together. But at a time of enormous news need, was it as good as it could be? Yeah. You know, I don't know. So I think if we did it again, we would have scaled up our communications and advocacy colleagues dramatically to have them have much more of a back and forth. But it was the reality of what happens in a panic situation like that.
Yeah. Now, if there were a bird flu, if this, you know, these isolated cases that we're seeing, of course, these are different variants, no need to panic. But if there were to be more generalized spread, what would happen, do you think, in the community?
Well, I mean, the first thing is, on the broader scale of things, are we ready? And I'll come back to the bird flu question, but let me give you an example of how we're not. So we keep the emergency stockpiles for all the epidemic diseases, for cholera, for yellow fever, for meningitis, and of course for Ebola. We have an Ebola Zaire stockpile. It's been used multiple times. You know, it's a lifesaver. It's a fabulous thing. When Ebola Sudan broke out in Uganda, this is a different strain. I mean, it's Ebola, but the vaccine doesn't cross-protect. There were some vaccines that have been worked on, but there were no vaccine ready to go into clinical trials. So, you know, people scrambled again, and 79 days later, there were vaccines available for trial. But of course, in those 79 days, one of two things would happen. It spread to 9 different districts of Uganda. It spread in the capital city. And that could have exploded. But luckily, Ugandan public health workers were able to control it. And by day 79, the epidemic was under control. Had it been the other way, we would have had it in South Sudan, in Kenya, in all over the place. So the question is, you know, why don't we have ready-to-use doses for clinical trials? And, you know, I could say the same thing for Marburg, which is recent, or many other diseases. So the answer is, again, it's a mindset issue, because what would that take? It would take having a few $1 million wasted. Why? Because what you do is you'd put the doses, you'd put them in vials, and if they didn't get used in a couple of years, they would expire, and you'd throw them out, and you have to refill vials. So, you know, the question for the globe is, do we want to have these vaccines ready to go, because they can be used to both see if they work, but then if they do work, to be used for control. So I don't think we're ready. Now, why do I use that? You know, the question is when do you push the start button for H5N1 or any other pathogen? If you had those types of funds, you could start producing at least prototypic vaccines so that you're ready to go. But where's the systems to be able to do that? So I think this is the mindset. And I have to tell you, the way we work in this is panic, neglect, panic, neglect, panic. Now, we're still in a public health emergency of international concern. And I can tell you, I'm having conversations with donors that are saying, we should shut down the COVID thing, and we should go back and take money that's available for that and use it for other diseases. As opposed to, wow, we have some money available for COVID, let's make sure we have that available in case we get new variants or it takes a turn for the worse. And if it doesn't, maybe we ought to take that money and use it for new infections and not go back to routine. So we still haven't come up with that mindset that the military has, which is, I'm going to prepare in peacetime, and I'm going to, be willing to spend a lot so that when something happens, I'm really ready to go.
Yeah, and I mean, that investment case is pretty clear. The size of the investment that would be required to do prototypical vaccines to be ready to trial. It's really not a large amount of money compared to the huge losses that we've seen with COVID-19.
$12 trillion.
Right, or even more localized kinds of outbreaks. It's still a huge economic cost and a hit to those countries. What do you think is not getting across to decision makers? Is it just that their political time frame is so short or is it that we're in this aid bucket and this is not really an aid issue per se? This is more of a global issue.
It's all of the above. I mean, I'm having previously run a product development public-private partnership, I was trying to tap into resources, but from the development community, but also from the health community and the research community. And of course, at COVAX, we also ended up working with the health community as well as the development community because of the donations and other activities. And it really needs to be as an existential threat, which COVID was. It shut the entire world down. As I said, $12 trillion worth of effect. And counting, right? Because we don't know what the long-term effect in education systems and people out of school and all the other things that are there. What you need is a commitment from government to not have this happen again. And as you said, it's not an expensive commitment, but it needs to be evergreened. And that's the really hard part because politicians have a very short attention span, and then another emergency occurs, and we should be able to handle 3, 4, 5 emergencies at once, not have them seriatim, but be thinking about them at the same time.
Let's shift now to another very related topic, which is, obviously the market for vaccines has completely transformed. Before COVID, there were 8 billion doses a year that were manufactured. Post-COVID, a multiple of that, at least double. And new countries involved in scaling up manufacturing capacity. At the same time, a sense by so many countries that they didn't want to be at the mercy of some external entity in terms of getting access to vaccines. So the push for regionalized manufacturing or diversified vaccine manufacturing, you've already talked about the need to increase the total volume, right? That's obviously the first thing. But what's the strategy to get there, and what's Gavi doing about that?
Yeah, so first of all, to talk about the market is really interesting. So if you go back to the beginnings of Gavi and working with the marketplace, we started with 5 manufacturers. 4 of the 5 were in wealthy countries. And today, pre-COVID, we have 17 manufacturers. The vast majority are in developing countries. The cost of the vaccines, 11 vaccines WHO recommends. They're not exactly the same vaccines because we don't have them in the US, but about $1,300 in the US. And we pay under $25 for those antigens. So that's the amazing change of the ecosystem we had. And that's been going from low volume, high cost manufacturing to high volume, low cost, quality manufacturing. We need to protect that ecosystem going forward, and that's an important priority. Now, you're right, every country is saying, I want to be able to produce my own vaccines. And of course, theoretically, any country can produce vaccines, but what you don't want is 203 countries producing COVID-19 vaccines, because that would not work very well, and you wouldn't be able to sustain a market for that. So the question is how to rationally do this. And the place that really didn't have a lot of manufacturing was Africa. Of course, we've been buying from a pre-qualified manufacturer in Africa for more than a decade now, in Senegal, but only one. And so there is now a question on how to move that forward. There now are 30 projects to strengthen manufacturing in Africa. So that's the good news. Now, most of them were directed at COVID, and we don't need 30 new manufacturing facilities for COVID. So what we've agreed in working with Germany and its presidency of the G7 is we put a plan together to work with the whole ecosystem to try to figure out which antigens we need more manufacturers for and which we don't, so there can be some rationalization of that. Again, not for us to choose who does that, but to make that information available. We procure more than 50% of the vaccines, for kids in the world, and so we're changing our procurement system to pay attention to these regional factors as well, and trying to work to create better demand signals in the marketplace for them. The last part of this plan is the most complex, because tomorrow, if you produce a new vaccine, and let's not call it in Africa, let's just say it's in the US or it's in Belgium or whatever, anywhere you produce it, the first vaccine that comes off the line is going to be really expensive because it's a super low volume, high cost. And so the question is, do you pay a high price for that, or how do you make sure you don't affect the ecosystem? So what we're talking about is creating a new advanced market commitment whose goal would be to subsidize a new manufacturer to enter a Gavi procurement for something that's needed, and to have them enter in a price competitive stage and then subsidize them for a period of time until they get there. Excuse me. The idea would be to try to have that keep the ecosystem intact while you support those new manufacturers becoming stable enough to, in peacetime, continue to support products that make sense.
Okay, well, it's great that you're working on the demand side, because a lot of these ideas about putting supply side subsidy or credit for developing country vaccine manufacturers is great, but if there's no market on the other end to purchase this, if countries don't commit to include it in their budgets going forward, there's not much of a future that subsidy can bring on its own. So it's great to hear that.
And just to say, because I didn't mention it before, one of the beauties of and learnings of the Gavi model is that every country pays something for every vaccine. You start off paying just a little, and as you get richer, you pay more until you eventually transition out. What that has created is line items in every country's budget in hard currency to pay for vaccines. And we need to make sure that continues as well, because if you don't pay for your vaccines, the most cost-effective interventions, then you're certainly not going to pay for other things that aren't. And so.
Okay, we're going to come back to this issue of co-financing, the fiscal situation, but let's now turn to the issue you also mentioned around vaccine delivery. Of course, there's the procurement of the vaccine, and when Gavi was born, it really was about sort of buying down the purchase price of new and underutilized vaccines, and the countries really, or other kinds of alliance partners, would help with the delivery. How has that evolved over time, your understanding of that? How would you hope to see the future in terms of Gavi, the Secretariat, working with the alliance partners to support countries better on delivery?
Well, first of all, again, looking at what happened in the last 3 years, there has been a reduction in routine coverage, and that's terrible, and it's enough in some places to cause outbreaks. It was about 4% reduction on average in 2020 and another 1% in 21. 22, we're not yet sure because we don't have final data, but it looks like there may be a recovery in many places. But big reduction, and that's really important in terms of how we think about that. But if we look at what happened in 20 and 21, there was obviously a massive pandemic, and during lockdown, 30 or 40% reduction. But what also happened is we began to roll out in 21 COVID vaccines. And so those health systems teams delivered 3.5 times the number of vaccines in 21, and yet the coverage rate for routine went down only 4%. So if you stand back, you say it's a tragedy, it happened, but it's remarkable how resilient those systems were. And people don't forget that. They start off and say, oh my God, it's been terrible, the reductions, but 3.5 times the number of doses and only a small reduction in routine. If you compare it to 2015, 4.5 times the number of doses were delivered. So what we've succeeded in doing is building a relatively resilient health system. But that's what we need to have more of. We need that system to reach every community, and we need to make sure that that has some resiliency for outbreaks. And that woman health worker who's now going to reach those zero-dose families, I mean, yes, we're worried about delivering vaccines, and it's easy to measure, but that's the same woman health worker who's going to deliver malaria interventions or nutrition interventions or whatever. And so how do we build that system out to that last mile? And so if I'm thinking about pandemic preparedness, I'm thinking about building the resilient immunization out system to the last mile and using that for all of these interventions and then being there for that emergency. That is something that needs to be a science, and we've tried to make it into a science. What does it cost? What do people need? What type of leadership and management? How do we build supply chains and systems? It isn't perfect, but that's kind of what the Alliance is doing in peacetime with its health systems grants, but also with the technical assistance and other activities that are going on.
Do you see a shift? Much of the health systems assistance goes through well-known international partners like UNICEF or the World Health Organization. I mean, as we think about really more direct-to-country health systems support, would you see the relative importance of those? Well, let me not ask it that way, but how would you see those kinds of grants evolving over time to support delivery?
First of all, it should be directly to countries. Full stop, end of story. That's where it was early days of Gavi. We did have a period of time where we got pretty sophisticated to build risk mitigation and risk awareness mechanisms, and we found some of the systems were not strong enough, and at that time there was not a lot of donor tolerance for risk, and so we pulled it back and we ended up doing some of the funding through partners. But we're trying to return it to government and country systems, and we're also trying to use, the International Auditors Council or order associations of countries to use their mechanisms so that those systems can be evergreened and be working on that. So that's the right thing to do. We also have been trying to expand to local partners for technical assistance because, again, over time, if we can get technical assistance to be locally provided with local leaders who understand their communities, that's also a really important model. So we're in a transition point. The UN partners have an enormous role to play. They are global, they're available everywhere. They are set up as member state organizations to provide support, and we want to continue to support that, but we also want to make sure that at the end, the program, the money belongs to the governments, and then we bring in other groups. Like when we're doing HPV, we need women's groups, we need cancer groups, we need as education groups, you need a different set of partners there than you do for a malaria vaccine than you do for a cholera vaccine, for example.
Since you mentioned the malaria vaccine, one of the issues is, of course, that you're really only financing vaccines and vaccinations, which is a world of good. But the question is, for something like malaria, how to think about what's cost effective in terms of malaria outcomes from a country perspective. Are we giving the best support from the international system to help countries decide how to get the mix right? How to think about new vaccines that aren't exactly the level of efficacy that we'd like to see, or the difficulty in administration, right? Because it takes 4 shots to immunize against malaria with the current vaccine. But how do you think about those issues in terms of how Gavi sets its priorities?
So we have a priority setting mechanism called the Vaccine Investment Strategy. We do it every 5 years for non-epidemic vaccines, and the idea is to look at all kinds of indicators. How cost effective is it? Is it going to replace existing interventions? What else has to happen? All these different types of indicators, and then we are able to rank vaccines and make decisions. I have to say, malaria is, in a way, went through that process, but one of the amazing things is what the demand is. So if I look at my African ministers, this is the vaccine they want more than any other, and they demanded it. In fact, when some people said, well, we don't know about cost effectiveness because of the efficacy, they said, this is our problem, this is the one we want. Now, you're correct, it isn't the most efficacious vaccine. It has about a 39% efficacy rate. On the other hand, malaria in hypodemic areas is so common that it's estimated for every 200 children you immunize, you prevent 1 death, which is amazingly cost effective. Now, of course, the cost has gone up. The manufacturing of the RTSS vaccine has not been ideal, and so the question that we had to ask is, do we go with a expensive vaccine right now and get it jump-started, or do we wait until we have a much more cost-effective vaccine? And the customers, if I want to call them that, said, don't wait, we want it now. So the board has agreed to move forward, but we're rapidly working to try to make sure there are other manufacturers who would step in. There are new products that may come, like R21, that may come fairly soon, but then there's a lot of innovation that's going on, and we may see other vaccines. So the hope would be this is the jump starting of a tool by the way, an additive tool. You have to continue to use bed nets and residual spraying, et cetera. But the beginning of that, which we will then have another, and then hopefully another, and hopefully much more efficacious vaccines over time.
Yeah, and I mean, that's sort of the idea of market shaping, right? Which is to sort of show that it works, increase the volumes, and then the cost may drop later. How do you, just thinking back on the pneumococcal conjugate vaccine advanced market commitment, you know, that was hugely successful. It delivered vaccines that were tailored to developing country disease burdens. And it, you know, really did work. But there was a big critique around the cost that was paid up front. It sort of relates to these other issues that we're talking about, the risk, the uncertainty, the market dynamics after you make those initial purchases. I mean, if you had to say something to donors or to the public that watches this, you know, what should we really be thinking about this? I mean, it feels to me like these are really marginal costs for the amount of benefit we're getting, but how do you see it?
Well, I would agree with you, but the question then is, you know, how hard do you negotiate? Now, at the time, there were 2 manufacturers who we thought could step in, and we had hoped that others would be coming very quickly. It turned out not that they didn't try, but the science was difficult enough that it took time before, you know, they could be there. And so the question then is, how hard do you negotiate the price? It's easy to sit back 5 years later and say, well, maybe we could have given a little bit less of a subsidy. I mean, you know, how many millions of lives were saved by doing this? And so, I mean, that's kind of the question you're in. If you had done it and only one of the manufacturers had joined or neither had joined, then you wouldn't have gotten the benefit. So it is a little bit of a question. It's also when we negotiated for COVID prices. We have the best prices. They're, you know, at the better than any other country, the lowest prices on every single antigen. You know, could we have gotten a little lower? Maybe, but, you know, again, the trade-off is, you know, we estimated by June of last year that we saved 1.4 million lives with, you know, those COVID vaccines. Should we have saved 1 million lives and gotten a better price point? I mean, you know, this is the question. So it's a little bit of an art, not a science.
Art, not a science. Okay, I'm being told that we have to move to questions. So if you can please come up and say your name and ask a very brief question or make a quick commentary here in the room. Or if my colleagues want to share something that's coming in via social media. I can't believe no one has questions.
There's one back there.
Okay, go ahead.
Hi, Tristan Reed from the World Bank. I just wanted to pick up a bit on this, what you said about the need for contingent financing. So I had a 2-part question about that. The first is, you know, if COVAX had had all the money it eventually did on day one, how would that have looked different? Like, how many would you have bought, et cetera? And then 2, you know, where is the conversation now on setting up that contingent financing? I know we have the pandemic fund for surveillance, but what about the response? Thanks.
So, you know, first of all, I mean, to be honest with you, the first question is unknown. Now, why do I say that? You know, I don't believe, and neither do you, that had Albert Bourla been called into Donald Trump's office and said, I want you to give me vaccines. And he said, no, I've already sold them to COVAX, that would have been an acceptable answer. I mean, I'm being a little bit facetious, but I mean, the truth is countries were going to take care of their own and get orders started. But if we had money available on day one, we could have gotten the order books, we could have had the conversations, we could have gotten at least some doses flowing, and as importantly, we could have done more tech transfers. I mean, you know, was the tech transfer to the Serum Institute of India successful or not? Well, you know, we paid for tech transfer of 2 vaccines there. We got some doses, and then there was an export ban. On the other hand, India had 2 billion doses out of that production facility. Had we had 3 or 4 other tech transfers, and there's not a lot of places that have that skill that they have, we might have been in a position to have provided vaccine in other places. So I think having the money up front is critical and an important part of what we should be thinking about. Not perhaps all the money, enough to get started, and then we should have an investor case and be able to move that forward. Where's the conversation? We've proposed the idea of creating an instrument and are going to do work on doing that. The question is going to be, will we be in the cycle of neglect such that people aren't interested anymore, or will we have support for doing that? I can't answer that question, but we'll do our best to try to get it out there. And this community, which is so influential, could be very helpful in trying to, make the case. Now, why do I think that's important? We have a pandemic vaccine pool now. As I said, there's some pressure even today on, if we're not using it, we should, lose it, use it or lose it kind of thing. If we were created, and we created for an IFM type, a facility, contingent facility, then the money's not sitting there. It's, and when you need it, it's available instantly, with a good trigger point. And I think something like that would be a much more acceptable way, given the cost of capital and the importance of the way it's used.
Yeah, well, I commend our audience to look at Tristan Shear Argawal's paper on day zero financing, and that's an area we'll continue to work on here at the center as well. We have time for one more question. Go ahead.
Hi, my name is Amanda Willett. I'm here with Crown Agents, representing colleagues who are in the UK listening in. They sent me a question in case it's not coming through. We're curious as a private sector player on what you see as the future for private sector and deployment, in particular reaching the last mile. I mean, you talked about community health workers, but I'm curious whether you see the future also involving private sector, which we know the U.S. government sees as critical to last mile delivery across the board. So just curious for your thoughts. Thanks.
Yeah, maybe can I ask you also to reflect on, what about fragile states where government really doesn't have the capacity to deliver?
So on the private sector side, we absolutely think it's part of the solution. It isn't the only solution. Government has a role to play. And so if we try to outsource the whole thing to the private sector, that would be a mistake. But we are using the private sector to do all kinds of work to increase logistics, to use the skills they bring, to bring innovations. And that has been an enormous success. What's interesting, though, is that in the cases where we brought private sector in to actually do delivery work, last mile delivery, again, they've been very successful, but when it comes down to saying to a country, how about now, memorializing this and using this for routine vaccines, et cetera, we've had a hard time getting people to do that. Now, some of the innovations like, drone deliveries or others have really been very successful and people like that, but for some reason, the countries really don't like that last mile delivery. We'll keep trying it, and we have metrics to show how cost effective it can be, et cetera, but it almost needs a mindset shift that says it's okay to mix some public and some private, and that both have places, and the pure public doesn't make sense, the pure private doesn't make sense, but a combination works. So we will keep working on that. Your question was on the...
So in fragile states?
Fragile states, yeah. I think, first of all, what's interesting is that we ended up providing about 65% of the vaccines for fragile settings. Mm-hmm. And in many cases, countries did the right thing. They included refugees, they included displaced people and others, and so people were able to get coverage through government systems. And I say the right thing because that's the best way to do it. But there are examples where the government disavows completely or there's no access, et cetera, and that's where we need to be able to provide vaccines. Now, we provide routine vaccines in those circumstances and are able to, work with international partners to do that. In this case, the liability was such a problem in terms of doing that. Liability, and the second problem was who accepts the vaccines. So, in general, the way it works is a manufacturer produces the vaccine, keeps the vaccine, then delivers it, and on the tarmac in the country, the vaccine is handed over and the liability for the vaccine is handed over. How do you do that in an area that doesn't have a government, doesn't have an official landing point, the stuff's being trucked in, et cetera, problem for fragile vaccines. And so this is a solution that needs broad engagement. I hope the pandemic, what's it called? Not treaty, accord. The pandemic accord might include a call for manufacturers to waive liability in these circumstances. Because in a way, I mean, if you think about it, these vaccines, by the time these discussions had occurred, they were in hundreds of millions, if not billions of people. The safety profiles were well known, and the likelihood of somebody in a refugee situation doing a class action lawsuit on a product that is known to be safe and is being used globally is pretty low, and yet that was a real barrier. And so I think one of the questions is, where this could be done is there could be an engagement if countries are going to fund companies to produce products for this. One of the things they could write in those, those agreements is that this should be available for humanitarian settings without a liability risk or something, there.
Or assume part of the liability risk.
We assumed, by the way, we had a no-fault compensation scheme for those countries, so they were included, including the regions that aren't country-driven. The challenge wasn't that, it was the indemnification and liability side. So that even reduces more the likelihood that there's going to be a lawsuit if you've already got, a no-fault compensation scheme in place.
Let's end with one question, which is, despite the COVID-19 shock, despite debt distress and recession, countries are becoming wealthier. There are fewer so-called IDA countries that are eligible for the World Bank's concessional lending window. Traditionally, Gavi eligibility has been tied very tightly to that low-income country line, although there's some exceptions made. When you think about the future of Gavi, how do you see the organization, or how might we see the organization evolve going forward?
Well, two issues. First of all, there's going to be a long tail there, and there will be countries that have enormous need. But the other thing is we've begun to shift into providing different type of assistance. So there is a middle income strategy. That is for countries that have transitioned out or for countries that have never been Gavi eligible, but are kind of in the next tier up, and we're working with them to try to get them access to reasonable pricing and technical assistance to be able to go ahead and purchase and get vaccines out. We're also working with some, quite difficult, fragile situations, as part of that strategy for countries that might have been wealthier to start with. I mean, Syria started that way. Unfortunately, they've been driven into severe poverty, but the Venezuelas of the world or the Lebanons of the world. So I see a role there. On the broader work on pandemics, the stockpiles are for global use. Now, if you're a Gavi eligible country, you don't pay, but if you're a wealthy country, you get them right away, immediately with no charge, and then you're expected to reimburse for those costs. So, I suspect we'll transition to a slightly different type of organization doing the same types of things. But I think, the really interesting question is, what do you think the future of vaccines are? And I'm pretty optimistic. We're going through a renaissance of vaccine technology and vaccine science. I think we already have 2 cancer vaccines. I think we're going to have a lot more. We're going to have vaccines against chronic diseases and immunologic diseases. And so I think we're in a situation where this powerful technology will have an influence in prevention around the world. And I think we're going to need some way to use to make sure that these products get to the places who can need them the most.
I think that's a very thought-provoking challenge for the future, and it's really about the future of global health all put together. I'm sure we'll hear what's next for you in a couple of months, but thank you so much for coming here today to talk to us so candidly about the challenges you've faced and the huge triumphs as well. And just, congratulations for an incredible tenure. It's been a really important time.
Thank you,
thanks
Amanda.
to all of you.
Thank you.